All right, welcome everyone to our high rounds. Today we have the pleasure to have Dr. Katie Riggs present an update on NeuroHIV from CROI 2023. But a little bit about Katie first. She completed her undergraduate degree at UCSD in biology. She then joined the U.S. Peace Corps, where she served as a community health educator for 2 years in Tala, Eastern Province in Kenya, with a focus on HIV and AIDS. She returned to San Diego and worked as a research assistant and clinical trial coordinator at UCSD's HNRC, which solidified her goal to become a physician to allow her to be a future research investigator and provide individual patient care. She went on to medical school at Kansas City University of Medicine and Biosciences, College of Osteopathic Medicine. After graduation, she completed residency in internal medicine at Scripps Mercy Hospital across the street from here. Dr. Riggs returned to UCSD in 2020 to pursue an ID fellowship, which she is currently finishing up. In addition to the clinical training, she's pursuing research focus on the neuropsychiatric effects of viral infections and associated immune dysregulation. So thanks, Katie, for doing this, and we look forward to your presentation.
All right. Sorry for the swapping around, but you're still on the right screen, right?
Correct, and I will be looking out for any Zoom questions, and for the most part, I'll probably let you go unless there's something that's really kind of relevant to what you're talking right now.
Okay, sure. Definitely feel free to interrupt if there's questions, because I know it can be hard to go back to the abstracts. So overall, so it will be talking about NeuroHIV. I initially wanted to include some neuro COVID PASC stuff, but that would be too much. So I'm just gonna break it down into mostly focusing on mood disorders, and then we'll talk about cognition, and we'll talk about kind of stroke risk biomarkers and neuroimaging to kind of separate it out. I think for me, the key themes from this CROI was basically trying to make sense of heterogeneity in all of our kind of in real world, in our research populations, et cetera. Sex differences were a big theme, as well as social determinants of health and the kind of Goldilocks balance between HIV and the immune response. So we'll start with mood disorders or brain health in people with HIV. And so just background to preface it, apparently this was the first CROI session ever on depression or mental health that was focused on a theme discussion about it. So that's surprising, but I'm glad we're there now. I think we all know that it is important. So just briefly, before I dive into the abstracts, just psychiatric disorders are more common in people with HIV, as we know, but the why is complicated. Depression is now pretty well established as an inflammatory disease, but it's not known if this is true for everyone with depression or just a subgroup. And we don't know if this, it probably also applies to other psychiatric disorders. And then antidepressants are less effective in people with HIV. So the why of this is complicated, but it could be, the why is because it might be inflammation from HIV, but it might also be social determinants of health, other medications, HIV itself, co-infections, ART. So trying to sort that out is difficult, but if there was a different etiology, it could point to perhaps new or repurposed treatments. So that's the real reason for doing that. And less depression, I think we know it's probably better overall. So the first one here is neuroinflammatory biomarkers mediate the association between HIV and depression. So overall, this was looking at HIV status, and then how that correlated or was associated with depression. And their hypothesis was basically that you would have an increased risk of depression in HIV due to neuroinflammation. So this is 125 people with HIV virally suppressed, and then 79 people without. And of note, this does exclude people who have severe depression. So anybody with a PHQ-9 over 15 is not in this data. First thing they wanted to look at was just the relationship between HIV status and any depression, which is defined as basically a PHQ-9 score of 5 to 15, or 5 to 15. And then biomarkers. So they found that being HIV positive, had an odds ratio of 3.27, higher risk of having any depression in this category. And so then the next step was to decide whether this was due to inflammation, and if that was different between HIV and or people with HIV and people without. So they added biomarkers into the different models, and they had a huge list of biomarkers of inflammation, and the main things that popped out were biomarkers of inflammation, especially innate immune activation and chemotaxis, which is MIG, or it's CXCL9, which is interferon gamma stimulated, and then TNF alpha, and MIP1 alpha and IL-6 and CSF. So it does suggest a different pathophysiology of depression in people with HIV. So I'm not going more in detail to it because I am trying to stay clinically relevant, but innate immune activation and pops up here as well. And then the other one, just want to talk about this poster briefly. This is based on charter data. So, and I think we see it in clinic, we don't have the single copy assay, but we don't necessarily know what the meaning of a viral load that is detected less than 50 really means. So this study used the charter cohort. This is all people with HIV, a sample of 69, and 50 of those had both blood and CSF. Others just had blood. And the main conclusion was surprising. So single copy HIV suppression, which this is not my terminology. It is very confusing. So SCS positive means no viral load. So it means suppression, positive suppression in the CSF. So single copy suppression in the CSF was strongly associated with more abnormal biomarkers of neurodegeneration, oxidative stress, and inflammatory cytokines and depressive symptoms. So that is, those that have less than one copy looked worse than those who had between 1 and 50. And so just some of the graphs to show this. So there were multiple markers, especially CSF markers, but also a couple plasma markers that were associated between the biomarkers and the CSF single copy suppression here. And so that you can see here, so A beta 42 is confusing because lower is worse. So this is showing that those who have single cell suppression in the CSF have lower A beta, and then same for the plasma. So same patterns here. Stricter suppression looks worse in terms of neurodegeneration markers, a single neurodegenerative marker. And then 8-hydroxy deoxyguanosine, I believe, or OHDG, is a marker of DNA oxidative stress or oxidation, so a measure of oxidative stress. And this also looked worse in the people who had both single copy suppression in the CSF and in plasma. That was significant. So they did look at cognition, and there was no relationship in this, relatively small study. But they did find there was CSF suppression was related or associated significantly to depression. So more suppression with worse BDI. And then also it was associated, the single cell suppression in the CSF was associated with a higher likelihood of taking TAF and abacavir. So, is this too much of a good thing? This is counterintuitive. We always think that less virus, better. But it could mean that if you have this restrictive control, that you have a heightened inflammatory state, and that possibly that a little bit of leeway from your immune system could be beneficial. This is obviously, we don't know this, but I think it is interesting and provocative and counterintuitive, so I wanted to share it. The part about TAF and abacavir is really confounding. It's hard to tell whether it's, is it neurotoxic, or does it mean that there's, the people who are on TAF and abacavir have other factors? Is it renal failure? Is it something else? And so that still needs to be untangled. So then the next one is, speaking of untangling, or trying to untangle the effect of ART or different regimens on depression. So this was a study that looked at combined, so the whole regimen, ART regimens, and they broke it into somatic depressive symptoms, so sleep, appetite, things like that, versus non-somatic depressive symptoms, which is more the sadness, feeling of guilt, etc. And so this is from the Women's Interagency HIV study, or WISE, which is all women. So it's 1,538 women with HIV who had at least 2 study visits and were receiving contemporary ART regimens. And the main conclusion was that regimens with tenofovir alafenamide and cobicistat are associated with more somatic symptoms of depression in women with HIV. So I am going to spend a little bit extra time on this one because I think it sounds, the conclusions were stronger than the data, I believe. And while this is not mainstream media, it's just to show that it is out there and on discussion forums and things. And so I think patients are likely to ask about this part. So I think just taking a step back of the risk factors or the complication of the overlap between HIV, depression, and all of the other messy life factors that we all deal with every day is pretty profound. So this is, in this group, I just think it's a nice illustration that they broke it into 3 groups of high level of depression. I actually can't see the top of my screen here. So low depression and then never depressed. And for that, while age actually wasn't that different, while race and ethnicity wasn't that different, highest level of education was different. So lower levels of education were higher in the higher, more depressed group, and less money in the high depression group, and more substance in the high depression group. And of course, this is very difficult to untangle between chicken and egg. Both of these they probably interact with each other. And so then, Okay, so I'll zoom in on this in a second, but basically this was, from here on out, they completely ignore the non-somatic symptoms. So I'm assuming nothing came up with that. For the somatic depressive symptoms, there's nothing in the low depression group or the no depression symptoms. And this is no depression, meaning this is using the CESD, which does have higher scores. And so they never met criteria for depression on 2 or more visits. Low depression, they had fewer than 50% of their visits with depression, and then high depression was consistent depression, basically. So it makes sense that the never depressed and the low depressed didn't have much variation. So we're going to focus on the high depression group. And so there are some red flags, which we'll get to, but I do want to say that all models included a lot of things to try to, account for confounding. They had cite race, ethnicity, education, income, which is great. They have time on ART prior to 2014. So I'm not sure what the reasoning for that is, because these were actually visits after 2014 too. And then current CD4 count, undetectable viral load, BMI, menopausal status, diabetes, and substance use. Interestingly, you can see must not have been in the West Coast because they don't mention meth here, but it was a little weird. There's no CD4 nadir and there's no duration of infection. It's just duration of ART. And so, as you may have noticed, it's a little weird. So the biggest thing that jumped out to me first was apparently efavirenz is good for depression. If you take this at face value, that people who are on efavirenz, TDF, and FTC, or tripla, are less likely to be in the high depressant group. So I think we definitely have red flags going off there. And then we come down to, their big takeaway was combining TAF plus cobicistat is bad. And it is statistically more likely that you will be on one of these regimens if you're in the high depression group. But I think we can see that, regimen is a surrogate marker for so many other factors, that even though they tried to account for a lot, they aren't, accounted for here. If you're on, this regimen, I'm assuming this is high level of resistance. I don't want to say salvage. High level of resistance, likely, have HIV longer, have a lot more lived experience. Maybe those on regimens with low barrier to resistance could have known better adherence, could be less likely to have, depression. And especially with the efavirenz, I think this means that it's confounded by prescribing practices. So, yeah.
Yeah, and so Katie just, Ron Ellis had put a comment in there about prescriber bias, and he says if depressed, don't use efavirenz. So
yes, so it's good. Yeah. It means that prescribers were not giving it to their depressed patients.
There was also one comment, since we're still on this, from Nettie. I've always been suspicious of some of the data on abacavir, and now TAF, since clinically we select those agents for people with renal failure or people we think are at risk for renal failure. And so she said it's hard to control for that.
Yeah, definitely agree. I think especially the one before with the single copy, yeah, it's hard to tease that out. And so, just the conclusion on this one, says TAF plus COBI is bad. It's associated with depression. They said, it's the fact that it's this combination that's really bad, and it's bad in women. But, they left out the fact that there's a protective effect with efavirenz. So I think they know that it's a little skewed, and that they recommend ART combinations rather than individual agents are associated with depressive symptoms. For me, I've already basically said it, but maybe it's an association, but I don't think there's any causality, definitely not going to change my practice, and I don't think going to change any of ours. And then it could be plausible. There are some signals for possible TAF toxicity. Cobicistat is a booster. You can have lots of off-target, polypharmacy issues. And we don't know if this holds true in men as well. And there's conflicting data. So, ta-da, dolutegravir is bad. That's making light of it. I'm not saying that's actually true here. So then we have, which we have heard before, this was a poster, that dolutegravir is associated with more depressive symptoms. Medications. So that is interesting. It's not, a super strong association. It's a little bit convoluted, but I think it is important to remind us to, just not jump on put everybody on dolutegravir because TAF and COBI is bad. And that interestingly, the depression or BDI scores, this is not BDI-3. I don't think we have that yet, BDI-2. Scores are not associated with abacavir, not associated with TAF, not associated with any other NSD. So I think the jury is out there. You could argue that it doesn't take into account the full regimen. It doesn't take into account TAF plus COBI. So that will be the next thing we look at. And the cohorts between this one and the last study I talked about are very different. The last one was women and had a, higher percentage of people who were Black, and this was mostly white men. So maybe there's a difference there. Maybe we need stronger studies. So then the next one I think was interesting in that psychiatric symptoms in people with HIV, prevalence, interactions, and consequences. So this is noting kind of an overall theme that, you don't just have one diagnosis most of the time. And so psychiatric symptoms often co-occur and can influence each other. And so they set out to do some network analysis to determine the interrelatedness of psychiatric symptoms and potential consequences. So they've got questionnaires from 1,600 people with HIV on suppressive ART. And the main finding was quality of life strongly impacted by depression, and that adherence to ART was not related to mental health issues. And we have a nice picture here. So I did think, this is, I think it is informative and it is interesting. It is a fairly decent sample size. And so, yes, depression and anxiety are, yes, best friends forever here. So very closely tied together right here. And there is also the attentional impulsivity, which is close, but these are very tightly close. And then we have ART adherence, which is all on its own. So this was really surprising to me, but interesting. So all these little purple are pretty isolated and not really connected with impulsivity, substance use, sexual risk behavior, their language, not mine, and quality of life. So I think that's interesting. We'll talk about that in a second. Substances and sex go together. Shocking. And then quality of life is most connected with depression. So I think it is interesting that, I expected quality of life to be, right in the middle here, affected by multiple different areas, but it really is kind of out here right next to depression. And it does have ties to other areas and other factors, but it is most closely tied to depression. And interestingly, feeling, they used a different depression score or scale, but the question of feeling slowed down was the strongest predictor of decreased quality of life. So I think that could be meaningful for us. It does translate directly to question 8 on the PHQ-9. I think that part's interesting. I think the summary from the mood disorders and mental health from CROI was basically starting to see the shift from diagnoses to specific symptoms, and to better understand pathophysiology, to translate to impact, and to hopefully eventually, I wish I could provide targeted therapies now, but hopefully we will be able to get there. And then I do think it was informative that at least in this one study, adherence was not related to mood, impulsivity, or substance use. I think most of us are not using that as a reason to, not give people ART, but further ammunition for that. And
Katie?
Yeah.
So Shannon was asking specifically, how did they measure adherence? If inaccurate estimates that may explain why, not linked to other factors.
True. It is self-reported adherence. So it is not pill counts or pharmacy refills. And I do know I have that, self-reported adherence is not the best, especially with a lot of other factors. So I did cherry pick that, but good point. And I think the jury is still out on specific ART regimens in depression. But there is a little signal that perhaps, immune response, going back to the single cell copy suppression and maybe TAF are a little bit of a double-edged sword. So then to talk about biomarkers, aging, and neuroimaging, it's kind of a little hodgepodge here, but I did want to talk about this one, which I thought, I think, can you still hear me? Okay. So for when I walked away, this was from CROI, this was one that stood out the most to me. And this is sex modifies the association of age and viremia with stroke risk in HIV. So this was Felicia Chow, and this was to investigate if sex modifies the effect of cardiovascular and HIV-related risk factors associated with stroke in people with HIV. And that there is, rationale for this, that they have shown previously that there's increased risk of stroke in women with HIV than men with HIV, but not really clear on the mechanisms or what those risk factors mean. So this is from CNIX, 5 CNIX sites, including UCSD. So 13,584 people with HIV who had a site that was participating in central stroke adjudication, meaning a neurologist formally reviewed it. And then they did Cox survival models, and we'll go through those. And the main conclusions is that sex does modify the effect of age and viral load on stroke risk. So sex modifies, or as I already said, so this is the baseline factors. This is people who had a stroke. So 162 people did have a stroke during this time period, and most did not. But not too surprising, but the differences are, older, higher or more women, more likely to be Black, and then more likely to have treated hypertension, diabetes, statin use, depression. But the BMI was not statistically different. And then we'll get to this, but basically, I think the most notable part is that viral load greater than 400 was higher in the stroke group and current smoking. So this is saying kind of similar. So those factors were different between stroke and no stroke group, but they did control or adjust for those in the models. And the stroke risk were typical things: older age, hypertension, diabetes, statin use, meaning that there's a reason they're on the statins. And then detectable viral load. And then there was a trend towards depression being a risk factor, higher BMI, and cigarette use. And then this is the part that was, I think, particularly striking, at least to me, was that this really varied significantly by age. And so for women with HIV, at age 40, the risk hazard ratio of having a stroke is, more than 2 compared to men with HIV. And then as you age, that actually changes. And so it's actually less likely, or a lower hazard ratio for women at age 60. So but it is pretty, I guess, surprising and eye-catching that at a younger age, women are at higher risk, is what I take from this. This is actually, the models are adjusted for stroke risk or disease risk score, which included all of these factors down here. And they did look for the sex by age interaction, thinking that maybe it was partly, different characteristics of the cohort. They did adjust for, they did add methamphetamine use, they did add depression and viral load, in addition to all of these other factors, which still remained significant. And then also looking at sex interaction for the relationship between detectable viral load and risk of stroke was much stronger in women. So for having detectable viral load, which I think was actually greater than 400 for CNIX here, the hazard ratio is 4.66. So having that detectable viral load really ramps up your stroke risk in women. So I think that is something that, obviously we want to be minimizing stroke risks overall, but definitely, and we want to have detectable, but another piece of ammunition, I think, and another thing to talk to patients about as well. And then, so the main conclusions were, like we talked about, sex modified the effective age and viral load on stroke risk in CNIX cohort. Female sex at birth was associated with higher risk of stroke at younger ages, and viral load was associated with higher risk of stroke among individuals who were female sex at birth compared to those who are male. And figuring out the mechanisms and of this is important to see if we can translate it into sex-specific prevention and treatment strategies.
Katie, there was a comment about, did they look at contraceptive use in the younger women?
No, I don't believe they did. They looked at menopausal status, but I don't think contraceptives were. I didn't see that mentioned. So that's a good point. And then this is actually an amazing study, but I am going to not quite do it justice in the interest of time. But if you do want to look up abstract 186, there was an oral presentation on it. It's very good. And this was looking at brain aging. So it was machine learning for neuroimaging, MRIs, and they looked at, so I think the two big takeaways for me were looking at people without HIV versus people with HIV who are all undetectable. The lines are a little bit different. This is actually a significant difference. And this means the steeper slope for people with HIV, even though they're undetectable, is that the brain age gap is greater. So they are looking at their imaging, it looks older than their actual age. But I think one of the really amazing things that points to some hope is how scattered these are. So while overall there is, a statistical difference, there are plenty of people with HIV that are way down here, have low brain age gaps. So it's not across the board. And then the other part, which I know other people have done, but I haven't seen it and I haven't done it in my research, was just looking as a way of determining social determinants of health, going by the zip code. So this was done in St. Louis, and they looked at an area deprivation index, which includes basically income, education, housing quality by zip code and small areas. And when you look at the brain age gap, spatial distribution, and you look at the dark red is highest area deprivation, or I guess worse social determinants of health, there is significant overlap between brain age. So pointing to the fact that outside of HIV, outside of whatever social determinants of health are important, which we know, but this is it was new to me, a new tool to me of how to actually look at that. And so I was excited by that. And then
Can I make, so there was a quick comment from Sanjay. There looked to be a number of people with HIV whose predicted age improved.
Yeah, there were. And so I think that's great that, people, it's all over the place. And so to me, it's really encouraging that the fact that everybody isn't going the same way. People are improving substantially over time is a good thing. So it can be changed and it's not a done deal that we just have to deal with. So I like that too. And then let's see, BPSP, so biopsychosocial phenotypes. This is in the charter cohort. You'll probably hear about it more at a later time. So I won't go into it as deeply as I had anticipated, but it's 1,500 people with HIV from charter. It is an older cohort. This is kind of mostly the baseline. And it took machine learning, looking at comprehensive neuropsych testing, plus self-reported cognitive symptoms, mood symptoms, and self-reported dependence in daily living. And did two-step machine learning, came up with 4 different phenotypes, which separated into overall fairly healthy. And then the other was depressed, otherwise very minimal or moderate, like daily impairment or cognitive impairment. The third group had some mild cognitive impairment, or very mild cognitive impairment, but reported severe depression and severe impact on daily living. And then the other was moderate neurocognitive impairment, but with no complaints, basically. And so I skip over this overall. There were some differences, but I think the most important part is, the reason to do this is that, specific phenotypes are trying to reflect the heterogeneity again in our world, and that it may be better than just looking at people who have cognitive impairment. So by adding all of these features in, and for example, people who have depression and cognitive impairment, may focus, or without cognitive impairment, may focus more on depression and traditional treatment of that, versus depression plus cognitive impairment may be more likely to do long-acting ART, long-acting depressant. Maybe when we have good neuroprotective agents, maybe we'll do that. And I am going to skip that for a moment. So cognition. So I think overall, let me see, what is my needed time?
You're at 8:42.
Okay, good.
Yeah.
All right. So plasma, A beta 42, A beta 40 ratio is not reduced in older persons with HIV. So you may be aware the FDA has approved that the plasma A beta ratio is available to screen for Alzheimer's disease. And a lower, like I mentioned before, a lower A beta 42 to 40 ratio is confers a increased likelihood of having more amyloid in the brain. So lower, bad. And interestingly, so they looked at people who had people with HIV who are cognitively normal, people, which is here, people who are cognitively impaired with HIV, people who are without HIV, but have symptoms consistent with Alzheimer's, and then people without HIV who are cognitively normal. And only the Alzheimer's group showed an abnormality. So I think the important part of this is there's been tons of talk of how are we ever going to distinguish, between HIV-associated cognitive, early cognitive changes versus early signs of Alzheimer's. And so this may be a tool. So if the A beta is low, it may make you think more along the lines of possibly earlier Alzheimer's. If it's not high, but you have some cognitive impairment, maybe more along the lines of HIV associated, but it's a tool. And then overall associations between plasma biomarkers, changes in cognitive function over 2 years. I don't think this was anything too monumental. Basically came up with that higher levels of, here I'll skip to the graph of it. So higher levels of soluble CD14 and MIP-1 alpha, which are activation or markers of macrophage activation and basically chemotaxis for linking with T cells for the MIP-1 alpha, was associated with cognitive changes in both people with HIV and without HIV. So that association was similar. So kind of pointing to maybe it's not all that different with HIV, but there was a at least a trend level interaction for at least MIP-1 alpha, that there was a stronger correlation with MIP-1 alpha and cognitive function in people with HIV. So, and MIP-1 alpha has come up often in HIV-associated neurocognitive disorders. So I think that's something to look at. And then also, this was important, in neurocognitive impairment negatively affects viral control in ART-treated people with HIV. So this mostly is, I think, there's lots of talk about most people who are screened nowadays with HIV, if they have any type of cognitive impairment, it's mostly lumped into asymptomatic neurocognitive impairment, or ANI. And there's lots of controversy about whether that matters, whether it means anything, whether it actually means that there's a higher risk of developing more serious cognitive impairment, or if it's just causing people to worry for no reason. But this is people who fall into the ANI category and significantly more likely to have virologic failure and even just persistent very low level viremia and persistent low level viremia. So that is, looking at regimen type, looking at years in the study, looking at ART duration, sex, all of these other things didn't matter as much as having, if you have more severe cognitive disorder, MND, the adjusted odds ratio is higher, but having ANI was statistically more likely to have suboptimal viral suppression. And for virologic failure, it was huge. So ANI has an adjusted odds ratio of 10.3 if you have ANI. So I think arguing that it's not so asymptomatic. And they did find that people who have virologic failure at that point, it is more likely to have global impairment across the board. But for the persistent low level or very low level, it's more short and long-term verbal and visuospatial memory, and not surprisingly, working memory and attention impairment. And then sleep disturbances, I think there's more to be determined there. Basically, this was a study that did show that this was, again, in women only, and it did show that there was poor overall sleep quality was associated with poor attention and working memory, processing speed. I think it wasn't super surprising. But interesting and more information needed. This one was initially very, I was excited and I thought it was great news, but I'm not sure it is all that reassuring. So this was cognitive trajectories among people with HIV modeled before and after starting ART. And this was done in Peru. It was 50 cis men and 6 trans women. And they, at enrollment, actually had significant impairment. They separated people based on their trajectories. So the different lines are all different trajectories, or basically different starting points, but they didn't actually differ very much by clinical characteristics or other characteristics, which is a little surprising, other than level of education. So level of education did correspond with initial testing. And then, but overall, these were very young, pretty healthy people who started ART pretty early. So the difference was they had people who started at enrollment, which meant that they had less than 100 days since their estimated date of infection, versus people who then waited 6 months after enrollment. So it wasn't a huge difference in ART start time, but they did look to see if ART start time differed by these trajectories, and it did not. But it doesn't account for practice effect. And so I don't think it's quite as reassuring as we hoped or as impactful. And so I think basically very brief summary is that these, more data-driven machine learning approaches are here to stay. I know that, it goes against the hypothesis-driven, and it makes people, including me, freak out about phishing expeditions and how real data is, but it's important. And it does give us a lot of new tools to really try to untangle the, high dimensional data. And then sex interactions are important. ANI is not so asymptomatic. Don't know what to say about ART regimens and depression at this point. And that's most of what I have. So it's not quite 8:45, but yeah, 8 minutes.
No worries. I think that was perfect. So we have about 8 minutes for some Q&A, and so we can open it up. And I think while maybe people are thinking about their questions, I did have I had two questions. First one is about the A beta 42 ratio. Do you know if that's available here at UCSD? If so, how much does that cost? Any ideas?
I don't know. I don't know.
Okay.
I don't think it's probably not paid for yet
Okay.
by many places,
Insurances.
but I think it was very recently
Okay.
FDA approved, so not yet.
To be determined. And then the second kind of question comment a little bit is that, you were showing a lot of the different data and different antiretroviral therapies, and it seems like our tendency these days is it seems like the prescribing regimens of people with HIV have become, it feels a little bit more homogeneous in the sense of a lot more people on integrase inhibitors, which which usually, if it's combined in a single tablet, then it's usually with TAF, FTC, and so it seems like if you end up studying patients and everyone's kind of on the similar regimens, you're going to find more associations with those kinds of components, whether that's like a dolutegravir or a TAF-based regimen. So I don't know. I'm always a little bit cautious with some of those types of results.
Yeah, I would agree, and I mean it is weird that bictegravir doesn't pop out when dolutegravir does, but yeah. I don't know what we can make of it yet.
All right. Any thoughts, other comments? Can unmute yourself if you'd like. I think we took many of the comments as we kind of went along, but.
Well, I didn't
All
even
right.
talk about mine. I could do that.
You've got a few minutes. Do you want to mention a little bit, or up to you?
Sure. I'll talk about it for half a second, for just a minute.
Sure.
So I think it was cool. It was interesting. And it was also a counterintuitive finding. So basically found that lower CMV DNA and peripheral blood mononuclear cells was associated with higher CMV IgG and worse cognitive performance. So it looked like CMV DNA was good for the brain. But again, it kind of reinforces this. Does this mean that a little bit of leeway, a little bit of more relaxed immune response, whether it's HIV or CMV, is possibly beneficial, or at least a little less inflammatory? And the most interesting part was there was a very small effect when you looked at the whole group. And it was, I believe, interaction, or it was like 0.018 for the p-value overall when you looked at CMV DNA versus global T-score. But when you looked for the sex interaction, which was a theme, as I mentioned, then it pops out as it's really an effect only in women, but it's really consistent across the different domains, which I think makes it a little bit more robust. It was the same finding if we looked at just HNRC versus just charter participants. And so it's counterintuitive. It's interesting, and I think it points to we have a lot more to figure out about CMV first, because it does modulate your immune system, as we're learning more and more. And it's possible that actually in the setting of HIV, it modulates it in a good way, or possibly a protective way in terms of neuro. But obviously it is not a good thing overall. But I'll stop.
Well, thank you, Katie, for a wonderful talk. You can check out the chat for a few nice words, including one from Andy Cates as well, too. So thanks everyone for attending today. Don't forget to do your CME by texting. It's today. The number is 439 to the number. It's in your, should be in your chat. Next week's talk is going to be given by Dr. Susan Little on HIV testing and prevention. So updates from CROI as well too. So hope to see you next week. Thank you again, Katie, and we will see
Thank you,
everyone
guys.
next week. Thank you.
Thanks.